This slide was prepared by one of our fellow. Now she is the junior consultant also, Dr. Rituparna Das. And because I didn't have the time to prepare this slide, so I'll be going ahead. But more important is I'll be sharing my experience when I'll be talking about this trigeminal neuralgia. So just initially, this is one of the classical report. How a trigeminal neuralgia patient presents with a sharp shooting, lancinating electric shock-like pain in one side of the face. This is a typical presentation. And mostly here, though it is mentioned as 40 years, but 40 years is not the typical age. Normally, the patients are more common is you're a little bit older, 50s, 60s. These are the the common age of the onset. And most of these patients will be having a normal neurological examinations, normal MRI. So diagnosis of the trigeminal neuralgia is made on the clinical presentation. It's a sharp shooting electric shock-like pain, one side of the face, and that lasts for a few seconds to few minutes. And then again, complete remissions, no pain, and again another episode. Initially, these episodes comes very infrequently, maybe a few times in a month. Gradually, these episodes comes more and more often, maybe once per day. And when the disease progresses, it will be several times per day. But this typical episodes, each episode of the pain means the sharp shooting electric shock-like pain. That is the characteristics of the pain, and that lasts very transiently but very painful. Trigeminal neuralgia is known to be one of the very painful, most painful conditions. So these are the the distribution, any of this distribution, either a first division, second division, or third division. So these are the little bit of history when it was described. They are the two names. One is your Daradia, another is Fothergill's disease. So, but again, you all know itself as a trigeminal neuralgia. So this is the one of the little bit of epidemiology. So the most common age is between the 40 to 80. But it is not that it is always 40 to 80s. I personally have seen the patient even in 18 years, 20 years. In fact, we presented one case of trigeminal neuralgia of 18 years of age and no vascular abnormality there. And we have not done any neuroablative case because the patient was too young, and we did the dry needling patient. That patient, we presented that in the journal also. Male is to female ratio is female are more sufferers. And this is again very interesting to see that in 2/3 of the situation, right side of the face is found to be involved. So it is peculiar, and we don't have any explanation about why, almost double than that of the left side. And no case, bilateral involvement, unless it is a secondary trigeminal neuralgia. Primary trigeminal neuralgia is always unilateral. Again, why it is always unilateral? Again, no clue why it is always unilateral. Why it is more on the right side. And another last one, again, this is another very interesting in the epidemiology, is that the third division is most commonly involved. So third division alone or in association with the second division is the most common. In almost 55% situation, we see third division is involved either alone or along with the other divisions. So now, the dermatome divisions, a quick recapitulation. This is one of the very common mistake, that's why this picture is important. That you see how is the mandibular division. Mandibular division goes up to here. So that means if somebody is having the pain in this area, many times I have seen our fellows has done the mistake, was telling, sir, it is first division. Because what is the common mistake? Normally they draw a line like here from the eye, from the mouth, and it's a common mistake that this is known as first division, this is second division, this is third division. So this is completely wrong. Look at the dermatome distribution. So this whole area, blue color, is your third division. So above the ear also, above the line if you're drawing, so that can also be a third division, second division. So this is a common mistake, that don't draw a line like in the lateral aspect of the eye and above that is first ophthalmic division. No, that is applicable only above the eyes. But the lateral to the eyes, it can be a little bit of second division, and mostly the third division is also there. So always remember that to understand which division is involved. So where is the Gasserian ganglion? Because the Gasserian ganglion is our target in most of the times. Though the trigeminal neuralgia is not because of the Gasserian ganglion pathology, but Gasserian ganglion is important. So medially there is cavernous sinus, the internal carotid artery, trochlear, and the optic nerves, very important. I have came across the situation, so the trochlear nerve palsy was there. I have found it. So medially, these are the structures. Superiorly temporal lobe, very important. posteriorly brainstem, again very important. And that is the reason why we are putting the needle, we are always afraid that don't push the needle too much. You might go more posteriorly and hit the brainstem, and you might be damaging the very important brainstem structures. So always be cautious, and you should be knowing about the boundary all around the important structures of there. So this is again, the trigeminal neuralgia is like after the Gasserian ganglion. So the three divisions comes out of the brain to the base of the skull through the three apertures. So the foramen ovale, the largest one. So through the foramen ovale, it is the third division, mandibular division comes out. Through the foramen rotundum, the second division, the maxillary division comes out. And the superior orbital fissure through which the first division comes out. So though to target the Gasserian ganglion, to reach the Gasserian ganglion, you always prefer to go through the foramen ovale. It's a large ovale, it is accessible. Percutaneously, you can access that ovale. You cannot never access the foramen rotundum or foramen ovale, superior orbital fissure. That means what I'm trying to convey the message that suppose somebody is having the second division involvement in the trigeminal neuralgia. Should we put the needle through the foramen rotundum? Or somebody is having the first division involvement. Should we put the needle through the superior orbital fissure? Answer is no. Though foramen ovale is through which the mandibular division, third division comes out, still to reach to the other division, we have to enter through the foramen ovale only. Because it is large and it is easily accessible, unlike the other two foramen. So this is again very common, at least my prefer multiple choice question. Through which foramen, which divisions of the trigeminal nerve comes out? So foramen ovale, the mandibular, foramen rotunda, the maxillary, the second division, and superior orbital fissure, the first division. So now the classification. So the classification in two ways. One is type 1, type 2. Another is your primary and the secondary trigeminal neuralgia. Sometimes the type 2 is also called secondary in some literature, but in some literature, it is type 2 is different. So what is the major difference to make it a type 1 and type 2? Or it's the primary or secondary. So let me talk about the primary and secondary first. Primary and secondary means what? Where we don't have a definitive diagnosis why it is happening. But this was, earlier when we had it. So primary, no diagnosis. Secondary, we have the diagnosis. Means there is a tumor, there is multiple sclerosis, there is sarcoidosis. So these kind of things are there which is responsible for the pain. And it can be bilateral as well. So this is primary where there was no cause. But nowadays, after we are having the MRI trigeminal protocol, many of these situations, we see the cerebral artery can be impinging the nerve rootlets, which can be a very important cause of the primary trigeminal neuralgia. That means, though we call it primary trigeminal neuralgia, though we call it that the cause is not known, but still, because this nomenclature was long back, primary and secondary, that time this kind of things was not available. So the MRI and the diagnosis was not available. That's why it was called primary. But in primary, the neurovascular impingement causing the trigeminal neuralgia is also. This is a very common mistake. That when we tell that yes, we see the cerebral artery is impinging the trigeminal nerve rootlet and the cause of the trigeminal neuralgia, even then we call it as a primary. So be very clear that the microvascular compression over the trigeminal nerve rootlet is within the primary trigeminal neuralgia. Secondary trigeminal neuralgia is the other things, multiple sclerosis. I have treated one of the patient with the multiple sclerosis. Multiple sclerosis is very uncommon in India. Still, that is one condition where there might be the bilateral trigeminal neuralgia. I told you earlier that the trigeminal neuralgia, primary trigeminal neuralgia is always unilateral. Why we don't know, but it is always unilateral. But multiple sclerosis is one such condition where it can be bilateral. And the other secondary causes can be sarcoidosis, can be tumors, the other secondary causes. So vascular impingement is also within the primary, not in the secondary. Now, this is based on the etiology. Now, based on the clinical scenario, it can be type 1, type 2. What is type 1? Type 1 is classical. That means what I mentioned, sharp-shooting, episodic, lancinating, electric shock-like pain, which is coming for a few seconds to a few minutes, is the classical presentations, and in between no pain. So that is your classical trigeminal neuralgia. So also type 1 trigeminal neuralgia. What is type 2 trigeminal neuralgia? Type 2 trigeminal neuralgia, this kind of classical clinical presentation is not there. In the type 2, there will be always some baseline pain. It is not that, it is a little bit of dull type. It's not sharp shooting electric shock like pain. Sharp shooting electric shock like pain might be there along with the dull baseline in the type 2. So type 1 and type 2 is based on the clinical scenario, and primary and secondary is based on the etiology. So now type 1 is always, the primary, and type 2 can be primary, can be secondary. That means some type 2 is because of the, the primary, means etiology is not known, and some type 2 can be because of the cause is, understood, like cancer, like other things. Is it clear? So many has this confusion. I have seen that they think that the type 2 is always secondary. No. Type 1 and type 2 based on clinical presentations, whether there is a typical classical presentation is there, sharp shooting electric shock like or not. Or if it is not there, if it is baseline pain, that is type 2. Type 1 is always, the primary. Type 2 can be primary, can be secondary. So this is very important. Type 1 sharp shooting, and type 2 is, the type 2 can be bilateral also, and type 2 is the dull acting constant, the burning sensation like thing. So these are the characteristics already I told. But very important is trigeminal neuralgia pain is triggered by chewing, speaking, touching, brushing. So the eating. So they are the things which can precipitate or trigger the attacks of the pain. Many times when the patients come in the OPD, they cannot talk. Whenever they are trying to talk, the episodes of the pain comes. And many times what happens, the patient just listen and he's just imitating, and the accompanying person is describing his or her sufferings. So speaking is one of the very important triggering factors. Chewing something, eating something, drinking something, touching the face, or brushing. They are the few very important things. And sometimes associated with each letter, the hemifacial spasm. Bilateral, as I told you, it can be seen in the secondary, but primary it is never, the bilateral. And what exactly is the reason for the primary trigeminal neuralgia? It is the demyelination. So why there can be demyelination? It can be demyelination because of the rubbing of the nerve with the vessel, or it can be because of the other causes, and sometimes aging process as well. So neurological examinations comes mostly normal, but allodynia, hyperalgesia is one. Differential diagnosis is very important. One is your non-specific facial pain. Other is your TM joint arthrosis, muscular migraine, the dental disorders. Dental disorder is so common. Many patients will come is all the tooth extracted thinking that it is a dental pathology. And another thing not mentioned here, which I used to add, particularly in the first division, where the cluster headache can be important, because cluster headache also causes very severe pain and pain around the orbital areas. So that can be confused with the ophthalmic division of the trigeminal neuralgia. So they are the differential diagnosis, and we have to exclude all these possibilities. But again, typical sharp shooting electrical shock like lancinating pain is a characteristics. So the MRI brain should be done. MRI brain can be normal. That cannot exclude the trigeminal neuralgia, but MRI brain is done for two reasons. One is to rule out the secondary causes, and even for the primary causes, we need to see whether there is a vessel which is impinging, cerebral artery is impinging. So now coming to the treatment. Always the treatment should start with the pharmacotherapy, and the drug of choice is carbamazepine. So carbamazepine should be started at a dose of 200 milligram. And initially carbamazepine is complete pain relief will be there. And it is also diagnostic. One of my, the dental surgeon friend is there. He always used to tell, whenever I have some doubt, I always give the Tegretol to see how is the result. If the pain is relieved, that means it is, the trigeminal neuralgia. If pain is not relieved, then it is tooth cause. So he is very, very intelligent, smart, and he always, whenever he is having the, some toothache or dental pain, he, try to exclude the possibility of the trigeminal neuralgia with some Tegretol. So Tegretol is so important, diagnostic almost. And oxcarbazepine is your another important. It's similar to that of the carbazepine, and it is having the less side effects because carbazepine has a long list of side effects, particularly the very dreadful side effects is the Stevens-Johnson syndrome. Apart from that, hyponatremia is also very important. Granulocytosis, so abnormal function test. So these all are the important the side effects of the carbazepine, but the most dreadful is your Stevens-Johnson syndrome. I have seen the patient with the Stevens-Johnson syndrome after getting the carbazepine. So you have to be cautious. You have to warn the patient that any side effects you have to report us, particularly skin rash after this drug. Patient has to report us immediately, and patient has to do the routine blood examinations as well as the electrolyte levels intermittently every 2 to 3 months, and to send to us whoever patient is receiving the carbazepine. So initial few years, patient will be very nicely controlled with if your diagnosis is correct, trigeminal neuralgia will be very nicely treated with the Tegretol. If not, then you think of the second diagnosis. You think that your diagnosis might be wrong if it is not treated with the Tegretol. Oxcarbazepine, I told you a little bit, and carbazepine, the very important, how it works. It is an anticonvulsant and it is a sodium channel blocker. Then the gabapentin, phenytoin, baclofen, other anticonvulsant. Personally, I have seen this baclofen is also a very important drug. It gives very good results. So after the carbazepine, what happens? Gradually, initial 6 months, 1 year, patient will be very nice with the 200, 300, 400 milligram tablet, Tegretol. Then gradually increase the dose. And as you are increasing the dose, patient will be having the dizziness, the imbalance. So these things will be coming. And that time you can add the baclofen. Baclofen is again very, very good drug. I have seen the second drug after the carbamazepine, which is effective, is your baclofen. I always, after the carbamazepine, I started the carbamazepine only with single drug, and then later on I add baclofen. And gabapentin I rarely add. It is also anticonvulsant. If the patient cannot tolerate carbamazepine, then only you think of gabapentin, otherwise not. Gabapentin is not the first line drug in the trigeminal neuralgia. So the few other anticonvulsants are there, and botulinum toxin is nowadays one of the options, which is one of the interventions which can be done. Acupuncture, peripheral nerve stimulations, all those things are there. But very important is your either surgical microvascular decompression or by these three percutaneous RF. These two are most commonly done interventions all over the world. So amongst all these things, even most commonly done intervention is your percutaneous radiofrequency ablation. So these are the important, but otherwise, if you don't have, you can think of the glycerol injection, retro Gasserian glycerol injection, and you can think of the balloon compression, particularly if the first division, if the V1 division is affected, and the microvascular decompression, if the patient is having with the MRI brain with the trigeminal protocol. So what you should write? Should you write the MR angiogram? Answer is no. The investigation of choice is the MRI brain with trigeminal protocol. Write it down. When you'll be seeing the patient, you should be writing in your prescription. If you're suspecting the trigeminal neuralgia, the MRI of brain trigeminal protocol. And what you are looking for? You are trying to exclude the secondary trigeminal neuralgia, and you are looking for any artery which is impinging the trigeminal nerve rootlets. So I'll be coming to these interventions one by one. So what is important? How to, the rule out, how to go ahead. So very important is, first you divide whether the patient is elderly or young. If the age is more than 50, if the more than 50, then whether the patient have the cerebral artery impingement or not, RF is your choice. Radiofrequency ablation of the Gasserian ganglion is the treatment of choice. Of course, after the pharmacotherapy. Pharmacotherapy is always first choice. When the pharmacotherapy is not enough, when the drug is having the very adverse side effects, then your interventions. Amongst the intervention, if the age is above 50, then your radiofrequency. If the age is below 50, then whether the patient is having the vascular impingement or not. If the vascular impingement is there, microvascular decompression is the treatment of choice. And if the vascular impingement is not there, then the radiofrequency ablation is the choice. So very simple, the algorithm. Above 50, below 50. Above 50, always, whatever the vascular impingement is there or not, you should be going for the RF Below 50, if vascular impingement is there, then it is microvascular decompression. If not there, then RF. And apart from that, other things are there. If the first division is involved, why first division involved, then the radiofrequency is not the choice. Because if we are thinking of the radiofrequency Gasserian ganglion ablation, the most important complication of the radiofrequency ablation is the loss of sensations. Some loss of sensation, not complete numbness, some loss of sensation is the commonest side effect of the radiofrequency ablation. And this hyposthesia, if it happens in the cornea, then there can be corneal ulceration. That is the reason why when the first division is involved, then we don't prefer to go for the radiofrequency ablation. If the first division is involved, then your choice is between three. The most evidenced for the first division is your balloon compression, because balloon compression do not have the sensory loss. Balloon compression might have the motor loss, particularly the mandibular division is having the motor fibers. So there might be the loss of motor fibers, but the balloon compression is the choice for the first division. Other two alternatives are there. You can go ahead with the glycerol injection, because glycerol injection also do not have the sensory loss that much. And third option is your cryoneurolysis. Cryo, you can do the Gasserian ganglion, and that can be helpful because that is also not causing the sensory loss. So the first division, they are the three choices. Second and third division, your choice is always, and fortunately, second and third division is the much more common. Second and third division, your choice is your the radiofrequency. And what kind of radiofrequency? Is it a pulse radiofrequency? Answer is pulse radiofrequency have a very high failure rate. So pulse radiofrequency is not recommended. So what is recommended? It is the conventional thermal radiofrequency what is recommended. Can you do the cool radiofrequency? Answer is no. Cool radiofrequency causes a large size lesion. So cool radiofrequency is not recommended in Gasserian ganglion ablation. It is we need a small size lesion. So we should be going for the thermal ablation with the conventional radiofrequency. So no to cool radiofrequency, no to bipolar radiofrequency. Bipolar radiofrequency is also going to give a large size lesion. No to pulse radiofrequency. No pulse radiofrequency, no cool radiofrequency, no bipolar radiofrequency. It is the thermal ablation which should create a small size lesion. What should be the exposed tip? Exposed tip should be 2 millimeter to 5 millimeter is the exposed tip what is recommended. So remember all those things, that when to treat, how to treat. So initially it is the Tegretol. Later on you can add the baclofen. If the treatment is inadequate or if there is a side effect of the drugs, then you should think of interventions. Intervention depends on your MRI findings and age. If the age is more than 50, then it is always RF ablation. If the age is, but obviously, except for the first division involvement. First division involvement, I told what to do. If it is below 50, then microvascular decompression if there is a vascular impingement. If there is no vascular impingement, then RF. And for the first division, first choice is balloon compression. Second choice is your Gasserian ganglion, the glycerol rhizolyolysis, or you can go for the cryoneurolysis. So this is in short. So foramen ovale is the important thing. This is the foramen ovale. So your needle should be entered through the foramen ovale, and in the foramen ovale, the lateral and if you wish to target another very important thing I forgot to mention for the radiofrequency advantage is you can ablate only one branch. For all other things, selective only one nerve block is not possible. But with the RF, you can do the only one nerve block. So if it is a foramen ovale, your needle should be lateral and the downmost for the mandibular, and of the ophthalmic, it is upper and the medial, and in the middle if it is maxillary. And most superficial will be the mandibular division, little deeper for the maxillary division, and most deep and the most medial is your ophthalmic division. But again, ophthalmic division, the Gasserian ganglion radiofrequency is not done. That is for your, what I told, balloon compression. Here the needle is, little bit more advanced. This is not the needle placement. You should remember the posterior cleavage. So this is the junction up to which you should not go. If you are going beyond that, there is a chance that you can hit, as I mentioned you, that this can cause the damage of the brainstem. So this is the Loxbone rekha. So you should not cross this Loxbone rekha. Your needle should be in between this part, this area, your needle should be there. So normally 3 lesions are done. First lesion is done with the 65 degrees, second lesion is done with the 70 degree, third lesion is done with the 75 degree. And what is important that it is less than the other conventional radiofrequency. So how you can go for the 80 degree, but here it is little less than 80 degree. The reason is that here the motor division is also there. If your temperature is little less, then the motor nerve is normally escaped. So remember, the commonest side effect of the radiofrequency ablation is your hyposthesia. Your touch sensation will be compromised a little bit. But that is normally accepted. For the radiofrequency, if we are doing at this temperature setup, then the chances of your motor loss is very minimal. But motor loss is more common with the balloon compression. But with the balloon compression, sensory loss is not there. So this is very important to remember. Balloon compression, no sensory loss, but motor loss. And RF, no motor loss, it is a sensory loss. And the glycerol in between these two. There is a very minimal chance of the sensory loss, very minimal chance of the motor loss. But still the glycerol is not that preferred. The reason is the glycerol, the early recurrence is very the high. And that is the reason why the glycerol injection is not that preferred. The preferred one is your RF or your balloon. So side effects is the weakness and the numbness. So any questions regarding the trigeminal neuralgia?